Chronic venous insufficiency of the lower extremities probably affects 20 to 30% of adults, and about 2% have really severe form, ulceration, very debilitated, unable to work. So this is actually a very large clinical problem, and the impact on quality of life is unrecognized. And using ultrasound guidance and very simple tools, sometimes thermal ablation tools, sometimes chemical tools, sometimes glue, we can close down that vein. It's a literally walk in, walk out procedure and eliminate that reflux, that insufficiency, almost instantaneously.
Deep venous thrombosis is a huge healthcare problem. It causes clots in your legs and they can go to your lungs. And pulmonary embolus kills more patients in Western Europe than AIDS and road traffic accidents and prostate and breast cancer combined. So it's a massive health issue. We think we can really help these patients by means of the skills and training that interventional radiologists have. We have the ability to take out thrombus, remove it, and reduce the risk of further problems for you as a patient. The results of the ATTRACT trial are coming out next year, should show for the first time definitively that deep venous thrombosis can be positively affected by endovascular specialists, and interventional radiologists are ideally suited to treat this patient population.
Well, after iliofemoral DVT, many patients will suffer from leg pain, swelling, venous hypertension, and this causes post-thrombotic syndrome actually. And despite anticoagulation, which is the current treatment, more than 50% of those patients will suffer from post-thrombotic syndrome. This causes a lot of loss of quality of life. And this is definitely undertreated and underestimated by many of our colleagues.
My talk today was about the role of foam sclerotherapy and avulsions in the sort of as an ancillary treatment to the other major treatments for varicose veins. The diagnosis of this problem, on the whole, the patients make their own diagnosis. Then the more detailed diagnosis of the problem comes with ultrasound scanning, which is a radiologist's role anyway. I would advise my fellow IRs to get stuck into this because it is something that gives you a relatively easy introduction to getting involved in clinical management. There are thousands and millions of patients out there who've got this condition. There will be no problem actually finding people that require your services.
These are generally very healthy patients who have a significant problem that's debilitating, that is easy for us to fix, and they will have decades of benefit from doing this. This is just a great patient group to start. If you're starting a clinical practice, starting an outpatient practice, this is the perfect group to start with.
Don't believe everything what textbook says, because there's always the opportunity to start with a new treatment. Second, DVT is undertreated, and we have to get involved in those patients to get the best out of the clinical outcome. And third, we have to get involved in the clinical decision process. That might also include that we focus also on ambulatory service to get patients coming to our department to get best treatment and to collaborate with other physicians treating those patients.
You have the skills, you have the techniques, you have the training to positively affect these patients by removal of thrombus, by dissolving the thrombus, and then opening the veins by placing stents. Or in the case of pulmonary embolus, physically dissolving the thrombus and reducing these patients' mortality massively. So I would say to you as a young interventional radiologist, look at deep venous thrombosis because you can really help these patients.